Let's get into the final panel of today, which is psychedelics and mental health. Ooh. Right. Long misunderstood and often stigmatized, these substances are now being revisited through rigorous science and compassionate intent, offering hope to those for whom traditional therapies have failed. Please join me in welcoming our incredible lineup. First, we have Dr. Milan Balakrishnan. Please give it up for him. Arey, use your sugar rush, guys. Come on. A consultant psychiatrist with over 14 years of clinical expertise, currently practicing at Bombay Hospital and Bridge Candy Hospital Trust, and heading the Department of Psychiatry at Masina Hospital Trust. Dr. Milan is a founder trustee of Bipolar India, a former secretary of the Bombay Psychiatric Society, and a member of the Indian Psychiatric Society's Digital Mental Health Committee. He's also a passionate educator and researcher, publishing extensively and guiding postgraduate trainees. His expertise spans treatment-resistant depression, anxiety, bipolar disorder, schizophrenia, substance use, and end-of-life anxiety. Tuesday with Maury, who said it? Combining pharmacology, mindfulness, psychotherapy, and innovative treatments like neurostimulation and ketamine-assisted therapy. Get ready as he joins our panel on exploring psychedelics, promising advances in treatment-resistant depression, PTSD, SUD, and end-of-life anxiety. Please give a warm welcome to Dr. Milan Balakrishnan.
Thank you so much, sir.
Next, we have Natasha Gandhi, everyone. Natasha has recently completed her MA in Social-Organisational Psychology from Columbia University. But her journey with psychology started long before, driven by a personal quest to understand her own experiences with invisible disabilities. Having lived with OCD and depression, Natasha brings not just academic depth, but first-hand insight into navigating mental health challenges, including treatments like ketamine therapy in India and the US. At IMHS 3.0, she will share her lived experience, offering a unique perspective that bridges research, clinical practice, and real-life journeys of those with treatment-resistant conditions. Once again, give a warm welcome to Natasha Gandhi. Last but not the least, we have Goel. A visionary entrepreneur. Behind Canazo India. They also have a stall over there, so make sure you check it out before you leave. The country's premier medical cannabis company. Hello, hi. Unrelated, country's premier medical cannabis company, and a name you might remember from Shark Tank India. Under his leadership, Canoza India is redefining plant-based healthcare with cutting-edge medical cannabis products and nutraceuticals. His journey is deeply personal, turning cannabis from relief from a neurological condition when conventional treatments failed. And today, he's on a mission to make science-backed cannabis solutions accessible to all. Recognized by Times of India, Silicon India, Good News Today, and awarded the General Leadership Award and Vinod Dixit Award, Sukrit also champions humanitarian and social justice causes across India. So please give this trailblazer a huge round of applause. And now, for the final panel, we have our moderator we know and love well, Preeta Saha.
Thank you so much. Hello everyone, have you had a good lunch? How many of you enjoyed the food? All of us? Superb. So we want to see a lot of energy, okay? Because after this panel, we have the research papers. So please stay back, listen to all the papers that the kids will present. And we will take a lot of questions for this panel because I know this is a very exciting panel for everyone. So welcome Dr. Milan, Natasha, and Sukrit. Thank you so much for being here. I think, how many of you are interested or, very intrigued with this topic? Can I see a... Yes, so it's a very unique field and it's a very interesting field. And so what does psychedelic-assisted therapy entail and how does it differ from recreational use of drugs?
So most importantly, of course, The differences are in terms of, I think before I speak, let me have a few disclaimers. One, that our experience with regards to psychedelics and psychedelic-assisted therapies far more restricted to the use of ketamine. The other things that we'll be talking about is not yet, of course, available in India legally. So we're still out on that one. But of course, there is research from the West that we've been sort of referring to. So that is clear that this is only the ketamine is the only one that we're using very clearly in a clinical setting. So in terms of when we talk about psychedelic assisted therapy versus recreational use, of course, the most important difference is intent, setting, and purpose, right? Where the intention is to initiate therapy in a safe environment where it's comfortable for the patient client to be administered ketamine or any other substance, and when that is happening, you're also available there to support him or her in case of any inadvertent side effect issue, anxiety attack, whatever they may be. At the same time, you are looking at exploring emotions in a way that you can. So it's also very clearly there is a pre-treatment phase where you're doing all the psychoeducation, understanding of what will happen through the session, and then what will happen during the session, as well as what will happen after the session. And following the session, of course, integrating the insights that come through during the session to sort of integrate it into the future therapy for the client. So, of course, recreational use, as we know, is uncontrolled. We don't know purity of substances involved. We don't know percentages. We don't know what is being taken, how much is being taken. At the same time, we know often that recreational substances too are forms of self-medication that patients or clients would resort to. Hence, that the recreational use may also give us some clues to what is helping this patient or client.
Thank you so much. So, in a country where recreational drugs are actually banned, but obviously it's illegal, but people use it, and it's also very casually glamorized, in movies and songs, etc. How can mental health professionals help clients draw a clear line between self-medicating to escape and entering a structured treatment like ketamine or psychedelic-assisted therapy?
So exactly, the whole idea would be through a lot of psychoeducation, because again, like you're saying, there's a lot of glamorization of substances, and substance use is fairly rampant, at least one in terms of people trying things out, as well as availability is very rampant. So we're going to have a lot of people who have tried various substances before. At the same time, we would like to be sure that we are educating patients properly as to why we're giving a particular treatment, what are the clear indications for it. Like with ketamine, the most common indications are treatment-resistant depression, and a very useful indication is acutely suicidal patients who need immediate treatment and response. That is a very useful indication for ketamine, and we see very good responses to that. And it has become, although when you compare ketamine to, so the most common treatment for actively suicidal patients, as we all would know, is ECT, right? But at the same time, when we are comparing that to ketamine, we find, of course, that for patients especially who, because of stigma and various reasons, or are not convinced to consider ECT, ketamine is a very effective option. At the same time, I always tell the patients that our record with ketamine is for the last 5 years. The research is for the last, say, 30 years. With ECT, our record is for the last at least 20 to 30 years, and we're looking at data going back to almost 150 years. So we know the robustness is definitely there more in terms of ECT, but are we looking at, if we are looking at an option where you feel that you're not comfortable with the idea of ECT for whatever reasons, family sometimes is not comfortable with the idea, in those cases, ketamine does work very well.
So ketamine is also used for end-of-life anxiety. So how does that usually, work?
Right. So when we look at ketamine biologically, just to try to keep it as jargon-free as possible, but we are looking at a drug that acts very rapidly. Ketamine is primarily used as an anesthetic agent, right? But we are using sub-anesthetic doses, which is almost 1/5 of what we would be using in anesthesia. And those doses would be injected intravenously very slowly over a period of about 40 minutes. While we do that administration, what we are also looking at is the changes that happen in the brain are very rapid. For example, we are looking at, while SSRIs take about a week to 2 weeks to act in terms of improving depression, ketamine tends to do that in a couple of hours. And the changes are very, very rapid. These changes are driven by a lot of glutamate release. And that also, what it does is increases the synaptogenic potential, which basically means we are promoting neuroplasticity very rapidly. So let's keep away from too much jargon, but we are looking at increasing neuroplasticity more rapidly, and hence the antidepressant effects are very, very quick. They may not last very long, but they still will last for a day or two, and then repeating those doses over 2 to 3 days for a course of about 6 doses would be the way to go about it. And then once things have settled, then there may be a maintenance treatment in the form of, say, a once weekly or even bi-weekly treatments. And once things are settled, we can go back to treatment on the standard treatment that was going on.
So back to medication,
Yeah.
back to regular medication.
Yes.
Thank you so much. So Natasha, I would like to ask you, Dr. Milan shared a lot of, medical. I want to hear from your experience. How has it been using?
Okay. So honestly, for me also, ketamine was like it was a lifesaver. Because I was again at that stage of treatment-resistant depression, acute suicidal ideation, where it really helped in the quick sense that an SSRI would never work. Like it would always take at least a week, like Dr. Milan said, or more than that. This, if I can give an anecdote actually. Before I started my infusions, I was actually at my brother's place one day, and there was a lot of noise from the road downstairs because he lived, on the 4th floor. And I remember just going into the room and shutting myself in because I was like, I can't take it. I don't want any noise. I don't want to talk. I don't want to hear anyone. And he's like, but we're not talking. What's up? And I was like, you don't understand. The noises in my head are so loud that I can't take any outside stimulus at this point. And after the first couple of infusions itself, those, whatever you want to call it, the chatter in my head, I wouldn't call it voices, but the noise in my head, it really subsided.
Wow.
It helps immensely in that. For me, it's also worked as, it's a push agent. In my worst moments when I've still had to be productive, I've still had to get my work done because, outside society is not as understanding. It's really, again, been a lifesaver, like I said.
Amazing. Thank you so much for sharing that. And I think there's a lot of stigma also attached to ketamine, like ECT, but because you hear how Michael Jackson passed away because he was on ketamine and obviously there was misuse. So how would you're a psychologist yourself, right? So when you talk to other people, your clients and your colleagues and your friends, when you tell them that, hey, you know what, I take the ketamine infusion therapy, obviously it's not just the psychiatrist who's giving the medication, but I'm sure there is psychedelic-assisted psychotherapy that's happening. So how has that worked for you, and what would you tell the people who are scared of taking this step?
That I think it would it'd be very dependent on what their fears are particularly, but I think I would try to help them as much as I can with anecdotes from my experience. So like I said, I would prepare them. My first infusion was a session where I've just wept. I just cried because I think it causes that kind of release where, you know, all the emotions just come out. After that, I think talking to your psychiatrist and your therapist about what will help the most during the infusion, because I was told by a lot of people, I did a lot of research, that listen to music, but music that doesn't have any lyrics. I actually didn't do that because I have a very specific band that I like and I love their music, and so I listened to songs by them through all my infusions, which really helped me because I developed a lot of insights. This may not work for everyone, so that's why talk to the person who's administering your ketamine, your therapist, what will help the most. It really helps to have a journal after the infusion, obviously not immediately when you're in that state, but afterwards journal the things that came to you, because it's a 1 hour, 40 minutes to 1 hour of immense insight. Because I think what the drug does is it can, and you want it to cause like a mild dissociation. So in that dissociative state, you really have a lot of insight. So it really helps to note them down, go back to your therapist, break them down. And yeah, I would say, for me, it's always been very clear, I don't want to suffer. I don't think most people want to suffer. So if there is a therapeutic intervention that can help where others haven't, I would say talk as much as you need to talk to get your myths, busted and your misconceptions resolved, and give it a try.
Absolutely, thank you. And how prohibitive are the costs for ketamine-assisted psychotherapy?
As far as I understand and know, most sessions in the city would be between 5,000 to 8,000 per session, which would be like a 6 to 8 session thing. So yeah, that's.
So it is a little bit expensive, but of course, you don't have to wait for 1 month for the medication to actually start working. So it's instant. Now this question is for you, Sukrit. Sukrit, you are not obviously working in psychedelic with ketamine, but you also work with something that is very closely associated with psychedelics, which is cannabis. So could you share with us how you got into this whole field?
Hello. So just to start with how I actually got into this field, so I actually had an AVM in my brain, so due to which I actually got half-side paralyzed and I couldn't actually speak. I had lost all my speech, I had lost my movements, and that was basically AVM is something, it's a small nerve malformation in our brain which bursts. There was blood all over, and because it was a clot, they had to basically put some glue, due to which it was done on my left side, due to which the half of my right side was paralyzed. And I tried like a couple of treatments and all, did not work. I couldn't regain my movements honestly, and that was where a neurologist at that time, because it was long back, from US told me, okay, it's something new, CBD, why don't you try that? And yeah, it's not that it happened like in a day or two. It took me somewhere around 8 to 10 months, but yes, I could gain back all my movements along with the physiotherapy which I was doing in Delhi that time. And I mean, now everything is perfect. Loss of speech, nothing. Did not need to go to a therapist. Someone told me I have to go for a therapist for speaking for 2 years, 3 years. Did not need anything, just that and physio. 8 months I was cured. Before that, 2.5 years I was on a bed rest. All doctors had given up that it would not happen, and I got that paralysis certificate of 80%. Today if I go, I mean, they would not even give me a certificate of maybe 10%. So yeah, that was the difference how I started CBD.
Amazing.
So yeah, that's where CBD got legal in India, and I thought, okay, fine, why not, if something is happening in US, start the same thing in India? Then along with the government of India, we talked and everything, because I mean we had good connections there. So I mean, after talking to them, we tried to get the same thing in India so it can actually benefit to the masses. Because one main thing, as doctor had also pointed out, how it is used. Because one thing, when you talk about cannabis, there are two forms. One is the smoke-up form, which is the marijuana, which everyone knows, which has a lot of health or other risk factors which is associated to it. Because I mean, you can have psychosis, there are terpenes, flavonoids, there's tannin to it, carcinogens to it. But now when you're actually doing it on a medical side of it, you take out everything. The only two things which are left is CBD and THC. CBD never gives you a high. THC, again, taken in the right dosages without anything else, will not give you a high. So that is where the medical cannabis comes into picture, and that is what we basically got in India.
That's amazing. So I think that answers my question. Ki what are the differences between Canazo's clinically formulated products
so I'll just tell you two things out there. So see, just to give a normal understanding, the whole plant of cannabis. So you start from the bud, which people normally call it buds, and the leaves, which people call it charas, ganja, or you can call it, like people call it bhang. So that is the raw form, which is not something which we use fully. So that is the whole form which people are taking and smoking up, which is having more than 150 types of content. Now what we do is, out of that, we extract and we filter out only two contents, which is majorly CBD and THC. Now over that, there are two more cannabinoids which are being still studied upon, which is CBN and CBG. CBG is basically said to be your all body has a endocannabinoid system in it, basically ECS system. So when you talk about ECS system, that is a type of system which is already being governed by the body. They already have something, in a very layman term, their food is CBD. Your body produces it till the age of 25, but after the age of 25, it stops producing the same. And that is where CBD comes into picture. That is why it's known as cannabinoid, taking a reference from the name of endocannabinoid, which is already there in your body. Now, what CBD does? CBD is something which works for any type of neuro conditions. It directly goes and to the CB1, CB2 receptors, it will bind, and then it helps to increase your GABA levels. It'll basically, when you're talking about serotonin levels, if you want to regulate the serotonin levels, that is where that comes into picture. So when I got anxiety, I had first tried benzos, I tried etizolam also, so did not work out, then I went for CBD. So basically what it does is, majorly when you talk about CBD, it is not psychoactive and it helps for anxiety, depression. We are talking about post PTSD, we are talking about for example depression, anxiety, or if you're talking about Alzheimer's, Parkinson's, or in the worst case, if you're talking about, sometimes there are very small kids also, it's already FDA approved with a patient base around 10,000 plus small kids, like 2 months to 2 years old. It was done for epilepsy, autism and ADHD, where it proved out that there were some certain drugs which could not work out, and that is where CBD came into picture. So that is something which can even be given to small kids. Normally dosage is somewhere around 5 mg to 10 mg of CBD. Now in the same way, when you talk about THC, I mean, we are already doing study with Tata Cancer Institute. That is something which is used majorly more for pain management, because where if a person is not having pain and then if he is taking THC, then obviously it'll make him high. But when if it is taken when there is any level of pain, just like how opioid medicines are taken, what happens is it goes and binds to the pain receptor, due to which the pain goes down, you don't get high. And majorly the thing is, it's not for normal type of pain, like you talk about very small, like a fracture, or you're just talking about a headache or something. It's majorly, we talk about cancer pain management, you're talking about fibromyalgia, we're talking about end of life treatment, that time that pain which you have for palliative care, that is where our study is going on, and which is proved very well, and it's already FDA approved also for that. So that is where THC comes into picture. Or else people are already onto substances or have taken into psychosis because they've done cocaine or any type of heavy substances. So for them, first from there we get down them to THC, because those people, because what happens, they already have used to a substance, they still want that same kick. That is what THC does. But now, because it is not addictive in nature, slowly and gradually you can taper it down, and post that we just shift into THC, for CBD. the body and the brain easily takes care through the CBD, and CBD is not addictive at all, no psychoactive stuff, and post that it can be left. So that is like we have around 10,000 plus cases of this particular thing which we've treated with around 100 plus doctors in India in the rehab centers. So that is where the THC comes into picture when you talk about any type of rehabilitation.
That's amazing. Thank you so much, Sukrit. So, Sukrit, you said that you were able to work with the government of India because you knew some people and it really helped. So, what legal, ethical, regulatory frameworks should India prioritize before allowing wider clinical use of these psychedelics or cannabis-based, interventions?
See, here the main thing is it should be prescribed by the doctor, because majorly, like right now, it's just prescribed by the doctor. But main what has to be done is, the scare the people have, be it ketamine or we talk about CBD or anything. The main thing is still there is not much clarity upon who can actually use it, who cannot use it. So it is pretty much clear by the government, but there's not much which has been told by the government to the doctors or the public about the legality. So one thing which I feel is very important is that when you talk about the medical associations and everywhere, government should be very clear upon what is legal, what is not. For example, you talk about CBD. A lot of actually doctors came to our stall and asked, can we prescribe, not prescribe? So now the thing is, it is something which is coming under a special class which can be prescribed by everyone. It has to be a registered medical practitioner, but it's not that it has to be a MBBS or a Ayurveda. It can be prescribed by each and everyone. It comes under phytopharma. Basically, phytopharma is a new stream which government had launched in 1.5-2 years back, which can be actually prescribed by everyone. Second, when you talk about this, doesn't come under narcotics. Not coming under narcotics, government has very clearly said can be kept by any doctor who has the normal FDA license to keep it, or any chemist. That is where it can be kept. Again, there people thought, okay, it's cannabis, maybe we are not allowed to keep it, but anyone who fulfills the norms of Schedule E medicine is allowed to keep it. There's no problem. They can travel with it all over India. Out of India also on a prescription can be traveled. The only place where they cannot, that is Indonesia and Singapore and Dubai.
All right. Thank you so much. That really helped. And I saw that you had certain bottles and products also. So those, I am assuming, are over-the-counter medications.
No, so we have both. We have over-the-counter and the prescribed. So when it's a doctor conference, you are allowed to take everything. I mean, that, as I told you, it's pretty legal. It's not something like, maybe you're talking about ketamine or some other thing. Maybe you're not allowed to take it everywhere. I don't know about that. But because that, as far as I know, it falls under Schedule X. Now, this falls under Schedule E. You are pretty much allowed to carry it wherever you want to carry it. The only thing is, whenever you're giving, it has to be done on a prescription. And the one which are over the counter, which is application, or the nutraceuticals that you're having, that's anyways under FSI.
So Scanazo has both, the Schedule E as well as the
normal ones.
Wonderful. Thank you so much. So Dr. Milan, I want to ask you, so again, with the safeguards that, of course, the government is having the regulatory body, what are the things, the safeguard training standards, multidisciplinary protocols that are necessary to prevent misuse and ensure ethical practice across psychiatrists, psychologists, and wellness providers?
Right. I think most importantly, we need a lot of sort of education within mental health professionals, right? Because that's, I think, a struggle that we will face, because there's again, with regards to, for example, when we look at cannabis, there'll be a huge divide among mental health professionals itself about where they stand on cannabis use, on recreational cannabis use as well. At the same time, we know that there is a cluster of people who, when exposed to cannabis, those who have a strong family history of psychosis, who've had previous history of psychosis, or who have like a high risk for bipolar disorder, etc., are prone to even getting triggered into an episode even by a single use of cannabis per se. So, of course, I'm not talking about CBD, I'm talking about recreational cannabis use. And they can trigger off these episodes. So that is a huge red flag. And with regards to ketamine also, we will be very careful in screening patients who have history of psychosis or risk of psychosis, because we know that during these dissociative episodes that they have during ketamine infusion, there may be a lot of disturbance, and there can be also trigger for psychosis. So I think this training, understanding, more conversations, reading up more research content, and trying to sort of streamline things, like we're talking about, more training, more awareness of seeing what are the settings in which, like I said, the indications are more or less crystallized. We need to stick to those as of now, because they have reasonably robust evidence. When we talk about the other psychedelics which are not available in India, even them, when we're talking about psilocybin or MDMA, all of the sort of research is still evolving. There is some evidence to say where there is a benefit, but then it's still a long time before we can convincingly say that we can use it across the board. But still, again, we're always looking at patients who are treatment refractory, who are not responding to standard treatments. So that's I think something very important. We shouldn't get into a position where we're using it across the board for all indications because of the rapidity of treatment, etc. So we always must be able to distinguish that this is like a backup treatment. This is not for all, but yet for those whom we must administer it to, it is very useful in terms of helping them quickly.
Thank you so much. Dr. Milan, I also want to ask you something. You said that, of course, when ketamine infusion is happening, that's done by a psychiatrist. And Natasha said that you talk to a therapist. So can any psychologist and therapist be a part of that journey, or does somebody have to have a specialization?
So most importantly, a person who would be standing by should, of course, be aware of what are the side effects that can happen. Should be able to also be trained at least minimally, or should have access to some support in terms of what to do in case of a crisis during the infusion. So those are things that we of course need more training, exposure to. Seeing these sessions may be like a helpful start. And at the same time, with regards to there are also courses that are available in sort of understanding psychedelic-assisted therapy. These are primarily also focused on what we can do after the session. That's, I think, something that therapists can have a more active role in terms of exploring what happened during the session. And like Natasha was saying, unless the patient has put things down, has started sort of processing what happened during a session, that's the only time that they will have enough information and data to work with.
Amazing. Thank you so much. So I think we will open up for questions. It's a great, can we have mic? Is that, okay. Someone over there is raising the hands. Can you please pass the mic later? Yes, you can take it back.
All right, so this was kind of the panel that I was looking forward to, because this is my fascinating niche that I'm looking forward to. But so my question is to all three of you, although I think two maybe more than the third, but y'all please give as much input as possible. So what are the most urgent steps needed to enable safe, ethical psychedelic research and therapy in India? And how do you see multidisciplinary teams shaping the future of psychedelic interventions? So, just to in general, since I was looking forward to get into this. In India, you can't even have there's no certified, not even a certified course to get into the specialization. Your best chance is US, UK, or Australia. So given with so much since yesterday till now, we've learned so much of taboo on the existing practice. And this is something beyond that purview. Ma'am has also experience, I would say, then another panelist has as well. And one of my friend does microdosing to control his anxiety to function. Yeah, friend, okay, not me. So I want to get your inputs, because this fascinated me is because generally it does ego dissolution, right? It reduces your DMN, your default mode network goes on a quiet mode, and it allows you more access to your brain, more neurons which you normally don't have access to, which is why it fascinates me. So I wanted to get your inputs on this.
I think actually Dr. Milan is the expert.
So, like you're saying, the issues with one, we're looking at psychedelic-assisted therapy as in an infant form yet, right? So it's very early for us to be able to, but still at the same time, we know that with time recently, things have translation of knowledge to practice has been much more faster than before. So hence, we are hopeful that things will obviously change. But at the same time, like you pointed out, I think there is a lot of need for lot of research to be initiated. But that comes with a lot of red tape and bureaucracy that will have to be experienced and done with, and it could be a long drawn process. But for now, what is available, definitely we can explore further, and research in that area is safe, because at the same time we're also dealing with a vulnerable population, right? So we are of course tied in by the I think there was conversation about the Mental Health Care Act and the SMHA, etc. So even research is more streamlined in that sense. There is more regulation on research, so that a vulnerable population is not taken advantage of in any way. Hence, all research will go through not only routine ethical clearances, it will also go through the mental health review board of that local place. And along with that, of course, because these are controlled substances, some of them may be like Sukrit said, Schedule X, for example, ketamine is Schedule X. So then the safety that we have to maintain, the records that we have to maintain are much more intense. So research, I'm sure, will pick up. Like you're saying, there is obviously a lack of training, because like I said, we're still in an infantile phase where we're also sort of evolving and learning, and then we can go to the next step of really training extensively. So I think, but like I said, we are hopeful that this will happen faster than we expect.
Thank you.
So I'd just like to add one thing now that the expert has spoken. I just feel also for research, my personal opinion is qualitative research, which is often undervalued, is extremely important in this area, because it wasn't until I had my experience and I spoke up and said that, okay, ketamine has been used for treatment-resistant depression. That is the indication that we know. But in my case, it helped immensely with OCD. Through experiences like this only, when people talk, is when you will realize, I came to know that there is, again, a difference between active and acute suicidal ideation in the true sense, and visceral OCD related images of self-harm, and there is a difference between those two. So when the person with the lived experience also contributes to research through these qualitative inputs, it really helps create that base for then distilling it to quantitative research. So that's my 2 cents.
Thank you.
Ramya, can somebody please pass the mic to Ramya? Yeah. Okay, sure. No, but they won't be able to hear you. So just a second. Yeah, it's almost there. Fast, fast. Come on, pass the parcel.
Thank you. So I'm fascinated by this area. In fact, I think in the US, if I'm not wrong, there are at least multiple companies that have IPO'd even before they've gotten a single drug out in the market related to psilocybin, things like that. These are like companies that are trying to research in this area without it being there. But just the factor of insight, the lived experiences that are out there that are much more than the negative experiences. There's just so much of talk, like the most prominent people around the world, like Musk or all of these other people, they have spoken about their own experiences. So invariably, I was very enthusiastic about this, and I was like, the first chance I get, I want to try, like ayahuasca, etc. But then, because I work very closely with psychiatrists, one psychiatrist I expressed this to, and then they were like, hang on, like your brother has an active psychotic issue. You should not consider taking a psychoactive substance recreationally or with like a shaman or even in a therapeutic setting. Now, is that true? Like, I'm sure there are so many people who are taking like recreationally mushrooms, these kind of things. Like, there is so much of interest in trying, but there is also this fear of what will happen. I mean, there are very different people on the panel today. Like, we'd love to understand from your experience.
No, I think the risk is definitely there because when we're looking at psychoactive substances, like I said before, whether it's ketamine or any other substance, we are always worried about risk of psychosis. Again, because there is a lot of unmasking of disorders that happens, and hence this concern with genetically vulnerable populations. And like I mentioned before, we've seen a lot of patients who have never had a psychotic episode before, with one sort of attempt with cannabis or any sort of triggering substance could push the patient into psychosis, and then the illness could be long drawn. So doesn't mean that you need to continue the substance to maintain the illness. So we're not talking about substance induced episodes. We are talking about substance triggered episodes, which may go on for years also, right? So that is a concern that will obviously be there. So then, and with medicine and with evidence base, our thoughts are always based on risk-benefit ratios, right? We are looking at, are the benefits far outweighing the risks of trying a new medication, etc. So when we talk about medication, we never say any medication is risk-free, right? Like I always say, that people who say that a medication is risk-free are fibbing, or it's not going to work, right? So we are looking at medications would have secondary effects which may not be helpful to that particular individual. So we are always weighing risk-benefit ratios. So if you feel that the benefits are going to be so high that they may outweigh the risks, that's the only time when you should really risk it.
Yes, the pros and the cons list is very important. Yes, to Netra, please. Netra had raised her hand.
Okay, my question is to sir. I'm in the field for quite a while now. I have done my full-time masters and everything, but recently got coined the term as TDCS. which is transcranial direct current stimulation.
That's her speciality.
yeah.
Ramya's speciality.
Yeah. Yeah, so like we are aware about ECT, we are aware about ketamine now to some extent. Now this is another thing, like we are not much aware about it, the things which are happening. Like, these are the 3 things which I just jotted down. Can you tell in short what's like, like for mental health condition, it can be a mood disorder
when we look
anything.
at transcranial direct current stimulation and RTMS, they would be more or less, they are neuromodulatory, neurostimulatory. RTMS, that is repeated transcranial magnetic stimulation. So both are more or less in the same group, where you're targeting a certain area of the brain to either activate it or inhibit it based on the disorder that you're trying to treat. For example, when you're treating depression, you're trying to focus on the part of the brain that's called the dorsolateral prefrontal cortex, and trying to stimulate it, which helps with reducing depressive symptoms. Again, useful treatments in terms of refractory, more difficult to treat depressions, or even we use all of these with OCD. Like the RTMS we use very often with OCD, and it works reasonably well. Again, in terms of, like I said, focusing on an area and triggering it directly. While in ECT we are looking at a more, let's say ECT is not as focused as these devices, but at the same time ECT seems to work better because it tends to stimulate the brain more holistically in that sense. But at the same time, of course, that also means that ECT tends to have a little more side effect in terms of temporary memory impairments, difficulties with like body aches, pains, etc., which you will not experience with TMS or TDCS. Again, with TDCS, the discomfort that you will experience will be locally. So the electrodes are actually put directly on the spot and then stimulated.
Consent is needed in all.
Consent is needed in all. Consent is basically.
Because I have heard that in ketamine, like patients that I'm not talking about patient.
Consent.
I'm talking about one person, like a family member. Or
Now again, the issues with consent are clear, right? When you're talking about a family member giving consent, it means you are saying that the patient does not have capacity to give consent. Yes, so if the patient does not have capacity to give consent, then the consent will be given by the family member. But at the same time, we must always have consent, because the consent is basically to say that the person has the capacity to understands the procedure fully, understands the risk benefits, and is able to choose one treatment over the other for the reasons that they understand.
One last question. Sorry. Anesthesia.
Mike.
We'll have to return back. No, like it's
But they also need to hear, na, Netra?
About anesthesia in all 3, where it is needed, where it is not.
So anesthesia is needed only in ECT.
Yeah.
Nowhere else anesthesia is needed.
Yeah.
Like I said, with ketamine, we're using sub-anesthetic doses. So some patients you may find patients who do have no experiences, in the sense they are more or less knocked out through the treatment as well. And also, depending on the dose, there may not be that full experience of the dissociative episode itself. So there will be some knocking out in ketamine, that is possible, but it won't be an anesthetic kind of going into full anesthesia.
Thank you so much.
That's amazing. Yes, I think we can take that one last question.
Hi, my question is for Dr. Milan here. In a scenario where it is mandatory and it is important to induce medication in chronic cases, But if a patient is suffering through pharmacophobia, how do you handle a situation like this?
So a lot of patients would suffer from fear of medication issues that are things that we constantly experience. Of course, like I said, we need to, of course, psychoeducate effectively. We need to be able to tell them what the advantages, disadvantages would be. For example, an episode of depression, severe, and you're saying that, okay, I want no pharmacological treatment, then you need to be able to tell the patient that it may remit the episode may still remit without any treatment in 6 to 8 months, right? That's the so the duration usually of a depressive episode is 6 to 8 months and will remit on its own even if not treated. But the struggles, difficulties that a patient may experience, go through during that phase, and the risks that may be there in terms of a severe episode with suicidal ideation, or with risk of ending up using substance as a sort of self-medication. So sort of being able to express to them the whole risk benefits of not treating versus treating, and then the patient is allowed to take an informed decision. That's the whole idea. But the concern very often is, like in a severely depressed patient, sometimes as we know that there is that sense of hopelessness that you're trying to navigate around. So that may be a struggle to get through. Also, we know that with depression there may be a lot of cognitive biases that may be there, which affect how you process the information about an illness, etc. So navigating all of those will also be important.
So in short, you kind of inculcate therapy as well prior administering medication.
Medication and therapy go hand in hand.
There will be that psychoeducational plus working on cognitive bias.
Yeah, because it can be difficult for phobic patients,
Yeah.
That's why collaboration over competition. We are not in competition with the psychiatrist, and we have to work collaboratively. Because it's us with them for the client. It's not you versus
we can't be in competition in any case, because in any case we're dealing with numbers that are beyond all of us.
Yes.
so
Yes.
there is no question of competition,
Yes.
because as long as we're doing a good job competently, and we're continuing to educate ourselves, I think we will have enough work to work with.
Absolutely. Thank you so much. So I would like to end today's session. First of all, how many you found this session to be very engaging and you learned something from today's session? Superb. Same here. Learned a lot of things about ketamine, with that the cannabis products are not directly, for getting high. So that's also something I learned recently. Of course, I've been watching your content on YouTube, so I've been stalking everyone, all my speakers. So the difference between a competent psychologist and an exceptional one lies in their commitment to ongoing research and learning. Constantly learning, constantly updating yourself, not just with courses and workshops, but also studying the research. That is very important. It falls on us. The masters ho gaya, and then I did one RECPT course, this and that, and I'm done. No, we have to keep studying. The latest researches happen, read it. It's very important for us to be up to date, because that is what is expected from us as psychologists. So I'm very grateful for everyone that came here to update themselves, know about it, and once you go back, I'm sure you will read about each and every topic that was discussed in today's sessions. And thank you so much. Afreen, over to you.